Okay, welcome everybody to our webinar today on why ambulance transport saves lives. We have a panel of some of our providers at Englewood. We have Dr. Aron Schwarcz, our Chief of Invasive Cardiology, Dr. Barbara Schreibman, our Associate Chief in the Department of Emergency Medicine, and Mr. Richard Sposa, our Head of EMS. Thank you guys for being here today on this very hot and muggy Wednesday to talk about cardiac and stroke emergencies, which unfortunately all of us on this call know affect a large proportion of people all over our country. For those of us who are somewhat knowledgeable about this information, some of the numbers might still be surprising to you. The CDC has us having about 1 in every 5 deaths in the United States secondary to heart disease, and about every 33 seconds, someone in this country is going to die from heart disease. Stroke is something a lot of people are aware of, but they don't know that almost 800,000 people every year have a stroke in this country. About every 40 seconds, someone somewhere in the United States is having a stroke. And of those people, if we start the stopwatch now, in about 3 minutes, one of them is going to die. So the reason we're having this is so that we can really raise more awareness about, one, how prevalent this is. A lot of people are surprised by the numbers, but also how, despite those numbers, we can improve this by getting to emergency care as fast as possible and getting to your nearest emergency facility as soon as possible to get care. So thank you, all of you, for volunteering your time to talk about this very important topic. We'll start first. I want to remind everybody on the webinar in general, if you have questions, there's a Q&A tab at the bottom where you could go ahead and enter questions there, and we'll get to them at the end. So in general, it's good to talk about symptoms. A lot of people have some information about it. We see a lot of pictures of how heart attacks look on TV, and sometimes it's made to look one way, and as practitioners, we know it doesn't always look like that. So I would invite first Dr. Schreibman to tell us what are some common and maybe not so common symptoms of stroke, and then ask Dr. Schwarcz to weigh in on the same thing for heart disease, some common ways you see it show up and some ways that people might be a little surprised.
Thank you, and welcome everybody. Stroke is very, very common. We see it frequently in the emergency department. It's a reason people often call 911 for emergencies. The symptoms can be very varied. They could also be very subtle. Weakness or numbness in an arm, a leg, a face. You can see facial drooping, change in the vision. Speech, it could be confused speech. It could be a garbled speech where you can't even understand the words, and someone could be very, very off balance. Depends what part of the brain is affected by the stroke. People have all different sort of signs and symptoms of it, and sometimes it's very subtle, but it's very important to come in and immediately be seen, because there are a lot that we can do if you come in quickly.
Thank you. Dr. Schwartz, any info that you want to share on heart disease?
Well, first off, thank you for having me. So heart disease, as you mentioned, is one of the most common, if not the most common, ailments that we deal with. Many people have heart disease, and it's still the leading cause of death in the United States. The classic symptoms, as what you mentioned, as gets portrayed on television, is the person clutching their chest and doubling over and sweating and feeling all the classic symptoms that we're all taught about. But as we come to know, people, as we say, don't read the textbook. There are plenty of other symptoms that, even though they may not be the textbook type symptoms, they're the ones that we commonly see. Could be simply as what somebody thinks as stomach pain. There was a young woman who I'd seen in the emergency room many years ago, who she thought she was coming into the emergency room because she was having some indigestion, some upset stomach, and she was actually having a heart attack. And we took her emergently to the cath lab to fix her heart attack. Very common, could be just be weakness, could be shortness of breath. People also assume that it has to be a pain, a sharp pain, but it could be a pressure, it could be a tightness in the chest, it could be jaw pain. Probably the most unusual pain that I've experienced was somebody who came in with ear pain and thought that they were having an earache. So they put some garlic as a home remedy in their ear, which got stuck, and that's what prompted their emergency room visit. And a very astute nurse in the emergency room did an EKG because their heart rate was a little bit elevated, and they noted that they were having a heart attack on their EKG. And that person was emergently taken to the cath lab, and their main blood vessel that goes down the front part of their heart, called the LAD, was opened. And if it wasn't for their ear pain and that garlic getting stuck in their ear, they would never have ended up in the emergency room. So symptoms can be very varied. That's why we've instituted in our emergency room that anybody over the age of 35 or 40 that's having symptoms above their waist is going to get an EKG, because the symptoms could be anything essentially.
Wow, that one is definitely the most unusual story I think I've heard. I neglected to introduce myself with the panel. I'm a staff endocrinologist at Englewood, and I have another unusual story to add to that. I had a patient who was sure she was having hypoglycemia, low blood sugars at home, and kept eating and drinking at home, thinking that she had low blood sugars. And when she finally checked, her sugars were fine. And what was happening was that she was actually having a heart attack. Thankfully, by then she had brought herself to the emergency room thinking, my sugars are fine, but I feel off. And that was all she could say, I feel off. And it turned out that she was having a heart attack. So quite true. Sometimes the symptoms are just not at all what you think they're going to be. So it's good to have a high index of, well, I don't quite feel right. So maybe it's time to get checked out.
And that's what makes it challenging, right? Because it could be really any symptom. And you may think that you're not having a heart attack, but that's why it's better to always err on the side of caution.
You'd be surprised at the number of patients that, even when we tell them they're having a heart attack, will argue that they're not. Because it's hard to admit that. It's hard to admit that you're having the scary thing. And it's, as both the doctors said, these things come up, and we have to pay attention, and the best way to find them is to look for them.
So we do a lot of EKGs in the ER.
So one of the things a lot of people commonly say, speaking to thinking this couldn't possibly be happening to me, many people say, well, no one in my family's ever had a stroke, or no one in my family's ever had a heart attack, so this couldn't possibly be happening to me. Would one of you like to speak to that as a very common thing that many people really do think, this couldn't possibly be happening to me because no one in my family's had this happen?
Well, genetics certainly plays a role, but being over 40 and having heart disease and smoking and untreated hypertension, illegal drug use, history of mini strokes, inactive lifestyle, these are all things that contribute to strokes and heart disease. So you could be the first one in your family who has this.
And you also have to think in the environment's changed a little bit than when a lot of people's parents were probably growing up or were getting older. Foods have changed, portions of foods have changed, processed foods have changed. Our lifestyles have changed. We're not walking and riding bikes as much as we were before. We're not keeping as fit as we were before. So yeah, even though parents may not have had, or siblings may not necessarily have had heart disease, a lot depends on lifestyle. A lot depends on what we're putting into ourselves in terms of what will determine how our overall health is and our heart health is.
Agreed. So along those lines, a couple of other misconceptions I think all of us have probably heard, and particularly since we're talking about getting to the hospital as fast as possible and why using the ambulance is your best, safest option. One of the ones we hear quite often is, driving myself to the hospital is going to be so much faster than calling the ambulance. Would anybody like to speak to that?
Yeah, I'm happy to jump in there, Dr. Ramsetty. So we do hear that a lot, and we see people that are very hesitant to call 911 for an ambulance because, again, I think some of that comes back to them not wanting to admit there's a problem, or exactly what you said. Well, I can just get there quicker. I think what is super important to understand that technology has changed so drastically in just the last 15 years, and certainly the last 5 years, of what we can do in the back of an ambulance, and the notifications that we can make from the back of the ambulance that are just, they're almost out of a science fiction movie. We're in constant communication. My paramedics are able to determine, at least, differentially diagnose a heart attack by taking an EKG right in your home or in the back of the ambulance. And if we see that heart attack, we don't just call the doctor in the emergency room, we certainly do, but we actually transmit securely that EKG from the back of our truck or from your living room right to Dr. Schwartz's phone, right to Dr. Schreibman's phone, and they are able to in real time see exactly what we're seeing. And keep in mind, while we're doing all this transmission, we're treating you. We're giving you medicine in the field. We're going to give you aspirin. We're going to give you medicine to help you. We're going to give you fluids. We're going to, check everything else about you, start that transportation process. But the important part is that notification. We're letting the doctors in the hospital know what we're seeing, and they're getting ready for us. So not only are they getting ready for us, sometimes the doctor's not in the cath lab, so they have to come in from home, or they have to come from another part of the hospital, or they're seeing patients. They're going to stop whatever they're doing and head right to that cath lab, and they're going to call their team to turn the lights on, get it running, and get it ready for us. And in many cases, with the coordination between the pre-hospital team, the emergency department, and the cath lab team, we're able to actually enter the doors of the emergency room, put eyeballs on that patient, and continue with the ambulance stretcher right up to the cath lab. And we take you from the ambulance stretcher to the cath lab table, and the process can get started that much quicker. Dr. Schwartz is famous for meeting us in the emergency room bay on the outside. He's out there when he gets one of those, and it's because he cares so much and he wants to be there. He wants to put eyeballs on the patient that we're already telling him is sick and needs help.
So you've answered one of my questions that I think a lot of people also say. The ambulance is really just going to drive me there. What are they going to do anyway? For something like a stroke or a heart attack, it's really just transportation. But what you're saying is that it's far, far beyond that. It's safe transportation, but in addition, there's assessment that happens, there's treatment that starts, and a great deal of coordination with all the other teams that patients will eventually get to. Is that right?
Absolutely, Doc. And to tell you the number of people that are involved in the care of a heart attack patient, it's probably in the hundreds in the first hour they're in the hospital. And we're starting that coordination where, as if you're sitting at a traffic light waiting for it to turn green, no one knows that you're coming. You're going to walk into a waiting room and you're going to talk to the people there, and they'll still get you the same results, but there's a lot of delays built in there that we can bypass.
I'm going to ask Dr. Schwartz, one of the common things that we often hear is time is muscle. What would you like to comment on that a bit in terms of getting you to the hospital as fast and safely as possible, in terms of what this means for trying to save your heart?
Yeah, I mean, that's a common moniker that we use all the time, which is time is muscle. And same for stroke, time is brain also. But for a heart attack, there's clear data, and this has been looked at, and we've known this for 20, 30 years already, that the quicker that you are able to get a person's artery open, the better they have their likelihood of survival, the better likelihood they have that their heart muscle stays strong, and therefore their survival is better and their quality of life after a heart attack is better. There are a number of different time points that we look at, and they've all been studied in the past. Symptom onset to the time that we get it open is key, and even when the first medical person that gets to you until the blood vessel gets open is important. And then from the time you arrive at the hospital until you get into the cath lab and get the blood vessel open is important as well. And these are all times that we look at and look at closely and continuously look at and continuously look to try to improve on. The quicker we can get that open, the better outcomes that you will have. And with looking at our data, and national data also supports this, if you call 911 and you have pre-hospital care by EMS and by paramedics, you will get that blood vessel open quicker, and considerably quicker. We're not just talking about seconds, we're talking about minutes sometimes. And that can make all the difference. And just going back to what Rick had said earlier, I mean, the pre-hospital care, the care starts in the pre-hospital setting when you call EMS. And that it can include some things as simple as giving aspirin, giving other medications that are available to EMS to give in the back of the ambulance, which then stabilizes people and makes them potentially healthier when they get to the hospital for us to treat. And that makes it much less likely that there is going to be complications when that treatment starts as early as possible.
And I think an important point as well is we're talking about, and we've been talking about up to this point, that patient that's having a heart attack that's awake. The reality is some of these patients are having heart attacks and will go into cardiac arrest before they get to us. And if you're behind the wheel of your car and your heart stops, you're certainly most likely not going to have a good outcome. You're going to potentially injure yourself in addition to your heart attack, potentially injure others or your family members. It really has to be at the forefront. And let's be honest, if I was driving a family member to the hospital and they went into cardiac arrest in my car, there's nothing I can do for that patient. Where if we're with that patient and they go into cardiac arrest, obviously we're going to start CPR, but we're also going to put them on a machine that does compressions in the field, quite frankly, far better than any doctor, nurse, paramedic, EMT can do them, because it doesn't get tired. It just is continual. And we're also going to secure your airway, and we're going to make sure that you're breathing and you're being oxygenated. So while obviously not ideal to have someone in cardiac arrest, the fact that we are able to circulate your oxygenated blood means that we're preserving that time as muscle peace until we can get the definitive care in the emergency room and or the cath lab. So it's a really important safety piece too.
Yeah. And we have had family members driven in and unfortunately go into cardiac arrest. It's unfortunately too real a scenario. And also with EMS, they also, if you're driving and you may be elsewhere, you may be going to a hospital that isn't in the forefront of treating strokes and heart attacks. EMS knows the best appropriate hospital to go to. You need a hospital like ours with a cardiac cath lab with a cardiac interventionalist available 24 hours a day, who will run in and take care of you. But starting the treatment early and giving us the heads up and calling in the teams are absolutely amazing and life-saving in these cases.
Yes, and I think it's important to note that Dr. Schwarcz and Dr. Schreibman and myself meet regularly on our door-to-balloon cases, and those meetings are part of the reason we're here tonight, because we're seeing an alarming number of people showing up to the hospital in their own cars, and we want to get the message out that that's not the best thing to do if you're sick. And that's why we're here. We're here because we're seeing this. It's not a what if, it's happening, and we're trying to get ahead of that and inform the public the best way to get access to this care.
Looks like we got a few more attendees, so I just want to make a quick break here to let everybody know again that we have a Q&A tab at the bottom of the screen. So if you have questions that you would like to send on to the panelists, we'll go ahead and grab your questions there and we'll save them for the end. I do want to ask also, Dr. Schreibman, can you talk a little bit about what happens in the emergency room and in the emergency room setting when you get a call ahead that someone is coming in via EMS who may be having a stroke? What does that look like from the ER side?
So, and again, one of the reasons to call EMS for a stroke is there's something called stroke mimics. There are a lot of things that look like strokes. And when EMS gets to you, they examine you, they look for signs of stroke, they check a blood sugar, because hypoglycemia, low blood sugar, can sometimes look like a stroke. So when we get the call that somebody is coming in with stroke-like symptoms, we alert, the doctor will get the call from the medics, we'll alert everybody in the ER, the charge nurses, but most important, the CAT scan tech. We tell the CAT scan to clear the machine, because as soon as you come in, we need to get an immediate CAT scan done. And if you're coming in, first you'd come in, you'd see a registrar, then you'd see a triage nurse, then you tell them your symptoms, and then they may have to get a doctor involved or call over to CAT scan. The CAT scan may say, well, we have somebody on the table right now in the middle of a CAT scan. Whereas with the call ahead, we clear the machine, we have you ready, we go straight from the EMS stretcher to a scale and then right into the CAT scan machine. We get the CAT scan immediately, because the faster you get the CAT scan, the faster you can get the treatment. And And stroke care is very much time dependent. There are certain things you can do within 3 hours of onset of stroke, and other things you can do 4.5 hours. There's also clot extraction that you could do a little bit later, but it's all timed. And one thing that's very important for everybody on the call to know, one of the most important things in terms of stroke is last seen normal. Everything that we could do within 3 hours or 4.5 hours or 12 hours is based on the last time you saw the patient normal, not when you found them with the stroke symptoms. So when you do call EMS, if you could remember the last time you saw that patient behaving normally, if you saw your grandma at 9 and came back at 12, and she was having stroke symptoms, the last seen normal was 9. And that's very important for us to decide what treatments we could do.
There's a lot out there that I think people aren't aware of in terms of what can be done for people coming in with a potential stroke of different magnitude. That people think about, little strokes or mini strokes, and they think about, quote, big strokes. And there's a lot out there that people aren't aware of that can be done to completely reverse it or to minimize the effects of that very quickly. And same with heart attacks and other things that may be happening related to the heart. So without getting really, really technical, because some of these terms are really, really sci-fi sounding, I would invite you to share maybe about some of the more recent technology that people may not be aware of. It can really, truly make a difference in preventing long-term consequences from a stroke or a heart attack, and what that looks like from when they get to the hospital.
Certainly in terms of stroke care, there's a drug called TNK, also TPA. There's just abbreviations for the clot busting drug. And it will help dissolve the clot that's in the brain. And there's also we call neurointervention. There are neurosurgeons who specialize in neurovascular disease, and they can actually take the patient to a procedure room. They actually suck out the blood clot in the brain. Patient meets certain criteria, and it's amazing the difference. And then people can get blood thinners, and they get worked up for why they're having the stroke. CAT scans, MRIs, neuroevaluation, but it all starts with recognition and calling 911, getting to the hospital as fast as you can. Obviously, and if you mentioned last seen normal, and please bring a list of medications that the patient's on. That's extremely, extremely important, because if they're on blood thinners, drugs like Xarelto, Coumadin, Eliquis, there are certain things we can't give. So it's very, very important, and that slows down care too if we don't know what blood thinners the patient's on. So that's something important to come in with. And I'll leave it to Dr. Schwarcz for the cardiac.
So for minimizing the effects of a heart attack, again, one of the biggest things, as we mentioned earlier, is that the earlier you get there and the earlier we're able to get that blood vessel open, the least likely it is going to be that there's going to be long-term effects. When you're waiting hours and days to get your blood vessel open, that's where you get the complications that can arise from a heart attack. So getting to the hospital as soon as possible definitely makes it less likely that any long-term effects are going to happen from the heart attack. For the past probably 15, 20 years, we've had access to emergently get the blood vessels open and be able to put in balloons to open the blood vessels, the blockage that's there, stents to ultimately keep the blood vessel open. We now have devices that can actually suck out the clots that are in the blood vessels as well, which we use in certain situations. And newest devices that we're kind of looking at there are certain pumps that can be put into the heart to kind of rest the heart. At this point, it's really used for people who have low blood pressures, or what we call being in shock, meaning that their blood pressure is extremely low and that they're in danger of having their essentially collapsing from low blood pressure or from going into cardiac arrest. And these devices have been used to help sort of stabilize the heart. And most recently, there's ongoing trials that are looking at using those devices to actually minimize the long-term effects of a heart attack and helping restore the blood flow and helping the small blood vessels that we don't really fix them, that we can't even see because they're microscopic, to help the flow get to those, which then ultimately help the overall heart pumping function, which is what makes us be able to get up and walk around and function and not have fatigue. So that ultimately having that pumping function be as normal as possible helps minimize the symptoms as well.
Amazing. I think a lot of people, when they think about heart attacks, especially, they're focused on aspirin and bypass surgery, and there's really nothing in between that a lot of people think about that can be done. And there's so much that can really be done.
Yeah, there's tons of things in between. We're actually not my cardiothoracic surgeon friends won't ever hear this, but we're becoming less and less reliant on bypass surgery, and there's more and more and more that things that we can do with fixing with balloons and stents. There are newer balloons that are coming out that we don't even potentially will have to put in stents in the future, and that we can just balloon blood vessels open, and you get a drug coating in the blood vessel that keeps that blood vessel open, and it prevents it from reclosing down the road. And you potentially won't even need stents in the future. That's obviously a hope that we all have, or dissolvable stents that are coming out. So there's all these new technologies, cardiology and neurology. It's one of the hottest topic type parts of medicine, where there's always, no offense to endocrinology, where there are always newer and newer devices and technology that are coming out that will help patients and help people and make my job a lot easier, and a lot more fulfilling, and hopefully patients' lives fulfilling as well.
Agreed. So I want to ask all of the panelists to comment on something I think probably all of us have heard at some point. And unfortunately, when we've sometimes heard patients say this, sometimes it's a family member relaying this to us because things didn't go so well. Oftentimes we hear someone at some point say, "I thought I had enough time." And they figured they would either wait it out at home, or it was safe enough to drive, or I've seen patients think that they might be having a heart attack but make a grocery stop because they thought they had enough time. And so I would invite all of you to comment on that idea of, I don't really feel like it's maybe happening. I think it might be happening, and I think I have enough time. What would you like to say to people when that thought crosses their brain?
Well, I can say from a pre-hospital standpoint, I've done CPR on a lot of those people. And I'm watching, the tragedy unfold in the house as the wife or the husband is saying those exact words to me as we're down on the ground trying to revive their loved one, because they just wanted to wait for the football game to end, or they were going to have dinner, or whatever it was. A lot of people, I think a lot of it is being afraid to admit your own mortality, or thinking that you're a little bit tougher than you might think you are. Don't wait. Don't wait. Pick up that phone, call 911. I think something that we didn't mention before is as quick as the ambulance gets there and we start our care, when we arrive and we're in communication with the doctors, your intervention care actually starts on that 911 call. And that dispatcher on the other end of that phone will be able to talk to anyone. Does not have to be a medical person. They don't have to know a thing. And they can talk you through a few of the steps that we've mentioned here. Turn your lights on, put your dogs away, get your medicines available, have a list ready, do those type of things. And should the worst happen, and the person goes into cardiac arrest, they can actually talk you through CPR right over the phone, with no education and no training. They will go through and talk to you, and you'll be doing CPR, before we even get there, which is the key. Bystander CPR makes a huge difference in these patient outcomes.
And all emergency medicine physicians have pulled people out of cars in cardiac arrest. It's very unfortunate. It's very sad. And the family, their wishes they had called 911. but unfortunately they thought they could make it. And in terms of strokes, a lot of times people bring in relatives, oh, grandma started slurring her speech yesterday, dad couldn't move his arm 2 days ago, and we waited to see, we thought it would get better. And then you're past the window for any interventional treatment. You need to come in right away, basically within the hour, so we can get the CAT scan and the lab work and start giving the clot busting drugs immediately. It's not something that you should sit home and wait for.
It's and waiting is not only, I mean, obviously in the extremes, it can be a life and death situation has been described, but it's also a situation between being relatively healthy walking out of the hospital and being sick and walking out of the hospital, having minimal symptoms going forward versus having multiple symptoms that can potentially almost cripple you in the future and be a lifelong issue. And if there's any question, any thought, it's always better to err on the side of getting checked, getting seen. I mean, Dr. Schreibman and her team are not going to complain about seeing other people in the emergency room because they were concerned because they were having chest pain. We would actually prefer having people being seen, and the best thing is, okay, giving you reassurance that this is not something that you have to worry about. This is something that you can follow up with your primary doctor or your cardiologist or somebody else. And we'd rather have more of those than have more people coming in cardiac arrest and pulling them out of their front seat, or pulling them out of the back seat, or people leaving the hospital and not able to walk more than 5 feet without huffing and puffing because they waited that extra 5 hours, that extra day, for them to get care.
Great. So, on a personal note, I think many of us on this call now have had family members personally affected by one or the other of those two. And for me, lots of my family is affected by one of those two. My grandmother in particular had probably one of the most amazing singing voices I think anybody has ever had. She would light up a whole church with her voice when she started to sing. She would stand up randomly and start singing. Embarrassing as a kid, but later I learned to appreciate this. And she had a stroke in her 70s, and she survived it, but it took her voice. It affected the part of her brain that enabled her to speak. And so the thing that all of us knew and that she enjoyed the most about her life was gone. And so I think about those things as well. We're talking a lot about the worst outcome possible, which is, I think many people would agree, is losing your life entirely. But there's so much in between that makes your life good. And much of what we're talking about is preserving that as much as possible by getting to the hospital as fast as possible. So I'm grateful that you've made that point so that everyone hears there's a lot that we're trying to save, including your actual life. There's a lot about your life that we want to save and help you be as healthy as possible for as long as possible. That really is the goal. So parting words, we actually do have some questions. I can get to the questions first, or we can have some final thoughts from the panelists. I give panelists choice on this one.
Let's do questions.
Questions, okay.
So
we'll do the question. So we've got a question here. What signs should we look for to help distinguish chronic migraines or heartburn from something more serious?
Dr. Schreibman, you want to take the stroke part and I'll take the
I'll do the chronic migraine part. If you have a history of migraines and you get one of your typical bad migraines that you've had, it's not any different than you've had it before, and you've had it worked up and you've had CAT scans or MRIs in the past, then it's most likely your typical migraine. We tell people if there's a change in the pattern, if there's a change in the way it presents, a change in the intensity, if there are associated symptoms that you feel your head's exploding, that there's something about it that's different, come in and get. Unfortunately, most strokes you don't get headaches, but from intracranial bleeds, strokes are generally clots, and you can have a bleed in your brain. That could present as severe headaches. So if there's any question, come into the ER, we get a CAT scan, and it's very easy to determine.
And on the heart attack aspect, in
Heartburn,
terms of
yeah.
differentiating that with indigestion, I mean, that's sometimes one of the most challenging things, unfortunately. A lot of the heart attack symptoms could mimic other things. But some of the things that you can look out for, and again, none of this is a 100% hard and fast truth. I mean, everything could be, there are some definitely gray areas with this, but if you have risk factors for heart disease, if you have high blood pressure, if you have high cholesterol, if you have a family history of heart disease, if you're over the age of 45 for men, 55 for women, postmenopausal women, all of those are potential risk. Sorry, forgot to mention diabetes, stroke, and smoking are all risk factors for heart disease. So if you have any of those are things that should essentially put up your antenna if you're having symptoms. If you're never prone to having indigestion and all of a sudden out of the blue you have indigestion, that's something to worry about. Indigestion usually is also related to other things that potentially can cause it. If you're eating certain spicy foods that always cause indigestion and you get indigestion, it's likely indigestion, but not always. If you are on certain medications that can cause indigestion. But if you haven't eaten anything, you haven't had any new medications, and all of a sudden you get indigestion, you got to think that potentially that could be related to the heart. And then there are other symptoms that you can look for that potentially are associated with the symptoms that you're having that could also push you towards thinking that this is more of a heart-related thing as opposed to just indigestion. So if you're having shortness of breath, if you're feeling clammy or sweaty, if the pain travels anyplace, if it goes to your arm, your neck, your jaw, your back, if it's traveling certain places, that also could be pushing more towards a heart-related thing. One of the things, though, that could go either way is nausea could be related to both the heart versus also related to the stomach. So that's not one of those that can really go either way. But again, if you're having any question or any concern, if you have a doctor, reach out to your doctor. If there's anything that is more concerning, again, don't wait and go to the emergency room, because that's where, you know what, even if you're having indigestion and it's very severe, they can give you treatment for the indigestion also. They'll give you stuff to treat that. So it's a win-win, really. And if it's a heart attack, you'll get care right away. So and EMS is also very good with also differentiating between that, because right, if you're having indigestion and you wait and you don't go to the emergency room, or if you decide to drive yourself, now you've essentially moved your timetable of being able to identify it back by 20 minutes, a half an hour, 2 hours. You call EMS, their antennas are up that this might be a heart-related thing. They'll get an EKG for you on the spot in your house, and we'll know sometimes right away whether or not this is a heart-related thing or whether this is something that maybe this is less of a concern for. So again, if there's ever any question, call EMS, get care right away.
That's a perfect lead in for the second question, which is written up. My dad went to urgent care and had an EKG that showed as normal, but was rushed to the hospital later that evening with a heart attack. Why was this not caught on the EKG?
So there's different types of heart attacks, and even within heart attacks, even with those different types of heart attacks, there are different types of heart attacks, and different blood vessels that potentially could cause a heart attack. So the classic one where people are rushed immediately with the EMS directly to the cath lab, those are what we call STEMIs, which are a technical term where there are changes on your EKG that are classic for having a heart attack. The blood vessels are completely blocked. They've started causing damage to the heart muscle, and that is now able to be seen on an EKG. There are other types of heart attacks, which we call non-STEMIs, which are which are heart attacks that don't necessarily show up or show up in a different way on an EKG, which is not a classic type of EKG finding, which again, if you have a high enough suspicion that it is something that's a heart attack, even if you have a normal EKG, that doesn't necessarily tell you that it's not a heart attack. An EKG that's abnormal in the setting of a heart attack is much more educational or much more telling than a normal EKG. A normal EKG does not necessarily rule out, as we say, a heart attack. You can have a heart attack even with having a normal EKG, depending on the type of heart attack. And then even within those, like I mentioned, even within those types of heart attacks, there's certain blood vessels that kind of go in the back part of the heart, and the EKG, which goes on the front of the chest, is not going to see something that's in the back of the heart. And so unless, again, there's a high suspicion, they can't be missed by just looking at an EKG.
Yeah, and I think something that's important to note is that when we review these cases each month, the first thing we start with is not the EKG, it's not the report, it's the story.
Mhm.
And the story about the case is maybe not just as important as the
It's just as important.
but I think it's just as important because, you know, if you tell me that your indigestion started after you ran a half mile for the first time in 10 years, my spidey senses are going to go up and we're going to think about it differently. If your EKG doesn't show anything crazy, but you're gray and you're sweaty and you can't catch your breath and you're clutching your chest, it doesn't matter to me that your EKG doesn't show anything, and it's not going to matter to the ED or the cath lab. They're all going to treat you with what we see, and the story is a super important part of the puzzle that we're trying to solve.
And one of the things, even if you have a normal EKG in the emergency department, which is why we advise people, men over 40, women over 50 who have chest pain, not to go to urgent cares with this, but to go to ER. Even if your cardiogram is normal and we're suspicious of a heart attack, we'll draw blood work. And we're looking to see if your heart enzymes are elevated. And that's a very important thing because you need sometimes, but if the cardiogram is normal, you'll need the heart enzyme test to see if it was a heart attack.
And having a medical professional lay their eyes on you can sometimes mean all the difference. There are plenty of stories, and I get called at 2 o'clock in the morning from one of the emergency room doctors that says that it's a person that just doesn't look right. Their EKG does not show a classic heart attack, but I'm concerned about this guy. We've given him medications. He's still having chest pain. I think you need to come in and activate the cath lab. And we have a great working relationship between the cardiologists and the emergency room doctors. We trust each other. We've worked with each other for quite an extended period of time that we know that we can rely on each other. And if one of the emergency room doctors tells me you need to come in, that's what I'm doing. It doesn't matter if it's 2 o'clock in the morning, 4 o'clock in the morning. If I was in the middle of a beautiful dream and a beautiful sleep, I'm still coming in. So it's getting to the emergency room by both EMS and them laying their eyes on you, and then the emergency room doctors laying their eyes on you can mean all the difference.
We've also had patients come in and their first cardiogram is 100% completely normal, and they're in the ER. We're observing them, we're examining them, we get blood work, and then we repeat a cardiogram in 30 minutes or an hour, and you can see that they're definitely having a heart attack. So you could have a first EKG that's normal, and then the heart attack progresses.
A follow-up to that question, there's a comment about, we have all of these tests. Is it possible to be proactive with screening tests and your lifestyle? There was no family history besides the father who ended up having the heart attack. And we talked about it a little bit earlier that, yeah, you could be the first person in the family who now has the family history. But to this idea of, well, we have all of these ways to try to look ahead. We have calcium scores and things like that. And we have, for many people, not everybody, but we have often better foods. We have information. We have guidelines on how active we should be, things like that. How does that play into normal aging and people thinking about, well, I've done all of those things. Could I still have a heart attack? What do you think about that?
Unfortunately, I mean, our screening tests are great and they're getting better every day, but they're not perfect. And a lot of times the screening tests can tell us what's going on in the here and now, but it's not necessarily going to tell us what's going to happen in 6 months from now, or a year from now, or 2 years from now. There are times when, yes, it definitely will tell us exactly what your risk is for having a future event. If you have a calcium score of 0 is very different than having a calcium score of 1,000. The data clearly shows that somebody who has a calcium score of 0 has a much lower risk of having a cardiac event within the next 3 to 5 years. It's not 0 though, unfortunately, but it's definitely better, and it's significantly better than somebody who has an elevated calcium score. But the more important thing also is that it can help us guide lifestyle changes. If you have a calcium score of, let's say, 50, I'm just using calcium score as an example, but there are plenty of other screening tests that we use to look for heart disease and to help predict heart disease. But if you have a calcium score that's not 0, but not necessarily high enough that we would do other testing, but yeah, that might help us and help us as doctors sort of guide you in terms of, we should be more aggressive with your blood pressure. We should be more aggressive with your cholesterol lowering. We should be more aggressive with changing your lifestyle in terms of your diet and pushing you more for exercise. And there are certain things, there are modifiable things that can be done to try and lower your risk. There are unfortunately things that are unmodifiable that we can't do, that we can't change, and that's always going to be there. Our age, our family history, those are things that you can't change. But at least the modifiable risks, we want to try to change them as much as we can. And the screening tests can help us in terms of how aggressively we should be addressing those risk factors that are modifiable.
And the same thing goes for stroke care. The things in terms of exercising, cholesterol, stopping smoking, following up with your doctor's blood pressure control, all helps you modify your stroke risk.
Okay, thank you all. We're gonna start tying up a little bit. So I invite you to share any parting thoughts. I think our main goal was really to impress upon everyone that time makes a difference, and safety makes a difference, and also to share the great extent of preparation that happens when a hospital system is activated from the EMS standpoint forward, and they know that you're heading to receive care. It's a much wider web than I think anybody really appreciates in order to take the best care of people, which is what we all want to do. Would any of you like to share any additional thoughts or a plea that you want for whoever's on this call and would like to share with their family members or for them themselves?
I think you're seeing a little glimpse into the coordination that you just spoke of, Dr. Ramsetty. You know, there are no silos within the hospital. This is a team with one goal, and it's the patients that are the goal. The patients having successful outcomes on the other end of that 911 call, or their ER visit, or their cath lab visit, you name it. This is a coordinated pre-hospital and in-hospital and then out of hospital network that makes all the difference in the world. You're not just hoping you're going to get the next best person. You're getting a team that meets regularly, speaks regularly, works together regularly, and we strive to provide the best care. The one takeaway is don't wait. Call 911 and start your care as quickly as you think there's something wrong. And if your family member tells you not to, deal with the argument later and call 911 anyway, because it might save their life.
I don't think I could have said it any better.
Right.
I think it's
You're right.
Big call. Okay, well, thank everybody for your attendance. Thank our panelists again, Dr. Schreibman, Dr. Schwarcz, and Mr. Sposa. Thank you very much for jumping on this call to bring us all up to speed and really remind us that time makes a really big difference for all of this. And we welcome anybody to go ahead and contact us later with any other questions, but thank you for your time.
Thank you.
thank you for having us.
Thank you.